This is credited by Hopkins. And so, again, this is going to be the first of two parts. But the goal here is to talk a little bit about what we know about the impact of substance abuse, violence, and depression on patient adherence, quality of life in the setting of HIV. And we're going to spend this portion of the talk today mostly on those. The next part of the talk will be reviewing screening and appropriate interventions and referrals. This is the disclosure. And we're very grateful for a grant from Gilead for this activity and for the for funding for this pilot project. So I'm going to go through some of this very quickly because I think you all are a very HIV savvy audience, but I think it's worth at least hearing a little bit about what we know about some of the interrelationships between these problems with HIV. I think all of us know that there's certain, I'm going to be focusing on women, but much of what we're talking about, and hopefully we can get some preliminary information from this study, better information about what is the prevalence of these problems in our patient populations that can hopefully lead towards better information about prevalence of these problems that can lead us to really looking at what systems issues may need to do. We're using screens that are in EPIC, but they are underutilized. I think all of you recognize that. So nationally, 87% of women who were identified with HIV in 2015 had previously tested positive but weren't receiving care. In 2014, about 2/3 of women with HIV received care, 50% retained, 48% had suppressed viral load. Now, we do a little bit better in Baltimore, 73% retention in care, 45% viral suppression. And as I think most of you know, we do extremely well in Bartlett with viral load suppression of around 89%. We know that there are certain predictors of non-adherence. African American women, women of color, are less likely to achieve viral suppression. And this is simply emphasizing the importance of viral suppression, which we all understand. The HRSA CDC message currently, and there was a lot of committees to try to craft exactly how the message would read, but this is the current message, that patients living with HIV or AIDS who take HIV meds daily as prescribed and who achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. And many people talk about the U equals U. And there was it was an extraordinary amount of discussion about effectively no risk, what exactly, what word to use. This is CDC data looking from 2010 to 2015. Nationally, the percentage of persons who are diagnosed with HIV who are virally suppressed. So it's gone up, but still nationally, only about 60%. This is New York State data. So it's looking at viral suppression among in-care patients living with HIV or AIDS by various demographics. And I think the things to notice are things, the subgroups that are still having inadequate levels of viral suppression. So particularly youth, age 13 to 19, transgender persons, you look at individuals of color, and women have slightly lower rates of viral suppression than men in this sample. This is Ryan White data, viral suppression among women served by under Ryan White in 2016, and overall women, and looking by age and some other variables, overall 84% of viral suppression among 95,000 women, and then looking at subsets under that, and looking in particular at, we know that perinatally infected women are much less likely to achieve viral suppression, although that is changing with better treatments, and women who have unstable housing. So you'll hear the term, and many of you may be familiar with the term SAVA, which stands for Substance Abuse, Violence, and HIV/AIDS. And this was conceptualized as a syndemic in 1994, as a set of closely interrelated and mutually enhancing epidemics, so that these each contribute independently to the collective health burden for women, but they also act synergistically to negatively affect outcomes. And so this has been called the SAVA syndemic. We felt as we were conceptualizing this pilot program that it was really important to look at depression too. That's not formally considered part of the syndemic, but I'll show you some data just on the interrelationship between all of these factors. So again, depression is independently associated with each element of substance abuse, violence, and HIV/AIDS, and that living with all of those three factors has been associated with a significantly increased risk of depression among women. And a study from Baltimore, 445 urban women who had experienced all three SAVA factors were almost 7-fold more likely to have depressive symptoms. And I'll show some data in a little bit about the association with lower adherence and quality of life. So first of all, just some general statistics. I think that most of us are fairly aware of these, but I think sometimes reading the numbers, the magnitude of the crisis is pretty dramatic. So in terms of substance abuse, 22 million Americans needed substance use treatment in 2015, but only about 10% of those actually received treatment. In 2015, 27 million Americans 12 or older were current illicit drug users, and drug overdose is now the #1 cause of injury-related deaths in the US. And this is, again, CDC data looking at the different drugs involved in US overdose deaths from 1999 to 2016. So you can see the huge increase in heroin and other opiates, including synthetic opiates. But you can see also an increase in methamphetamine and cocaine, which I think we sometimes tend to forget about a little bit. And this is Maryland state data looking at similar drug overdose deaths, also included alcohol. And you can see the big increase in fentanyl overdose deaths. This is data from 2007 to 2016. If you look at some other general statistics, as you begin to look at some of these other issues and their interactions, interpersonal violence, 31%, so a third of US women experience physical violence by an intimate partner during their lifetimes. 47% experience psychological abuse, and 50 to 60% of women who are on public assistance have been victims of domestic violence as adults. The costs are extraordinary, almost $6 billion yearly. And if you look at depression, the statistics show that 7% of US adults have had at least one major depressive episode in the past year, and with a lifetime prevalence much higher. So then you start looking at some of these interactions or interrelationships, and particularly with HIV. So we know that many of these factors increase HIV risk, the risk to acquire or transmit HIV. So physical interpersonal violence alone increases the risk by 28 to 52%. The risk is most significant with sexual violence. And women who have violence in their relationships are also at increased risk for other sexually transmitted infections. So you start seeing a real circuit in terms of increased risk of STDs and increased risk of HIV. I don't think we need to talk about substance abuse as a major risk factor, both injection and non-injection drug use, and alcohol use. So violence and mental health and substance abuse, again, have a strong interaction. So IPV survivors have a much higher rates of trauma-related mental health conditions, in particular depression, nearly 3 times the risk for a major depressive episode or PTSD, and those who had a recent history of violence, nearly 6 times the risk of problematic alcohol use. You can see that the prevalence rates of substance use and abuse among IPV survivors vary significantly, but in some studies is as high as 72%, and likewise the prevalence of IPV among persons using substances varies, but is high. This is just a graphic looking at sort of the interaction particularly between violence and HIV. And I think that if you look at exposure to violence, you can see the antecedents, but then some of the things that have been associated with exposure to violence, including risk behaviors and unstable relationships, and all of which will increase the risk of HIV. Looking at the risk for violence, substance abuse, and depression among HIV-infected women, women who have HIV, it's been shown, experience more frequent, more severe violence at over 2 times the national rate. The depression is the most common psychiatric comorbidity among persons living with HIV. It affects 30 to 40% of infected adults, 3 times higher than in the general population. And women with HIV and women without HIV have significantly higher rates of depression than men. About 50% of depression goes unrecognized, and about 50% that's recognized goes untreated. So a lot of interactions there that we are presently not capturing well in our evaluation and our care. This is data from published a year ago looking at substance use disorders among persons living with HIV, and quite high. It breaks it down by the type of substance. So 19% of individuals living with HIV have a substance use disorder related to alcohol, opiates 4%, cocaine 11%, marijuana 31%, methamphetamine 13%. And all of this has been related strongly. Many of you are aware of the trauma-informed care and PTSD that some of the investigators like Eddie Mackinger at UCSF have really brought to the forefront. There's a 10 to 20% prevalence of PTSD in the general population, but it's much higher in the setting of HIV, where some studies have showed a lifetime prevalence of 54% and prevalence related specifically to HIV of about 40%. Women, again, more likely to have a diagnosis of PTSD, and patients with PTSD are significantly more likely to have substance use disorders. And this was from a meta-analysis that Mackinger and colleagues published looking at the prevalence rates of traumatic events and PTSD in HIV-positive women. So if you just look at this third column at prevalence and looking at some of these, 55% violence, broken down, 35% was adult sexual abuse, 53% adult physical abuse, 39, almost 40% childhood sexual abuse, a little bit higher than that, childhood physical abuse. And then very high rates, so lifetime sexual abuse of 61%, physical abuse of 72%. So really pretty dramatic. This was a study published about 3 years ago looking at 563 HIV-positive women of color. 2/3 of those were African American and 26% Latino. And it looked at the relationships between 5 psychological factors associated with SAVA, and looking at the relationship. And I think you can look at these factors: poor mental health, substance use, binge drinking, IPV, and sexual risk taking, and then how they interact with each other and the increased risk. And so you can see that many of these have a statistically significant increased risk of one of the other factors, and because of some of the relationships we've discussed. So taking that over into its impact on patient outcomes, this is from the same study that the last slide addressed. As the number of psychosocial problems increased, the likelihood of viral suppression decreased. And there was the suggestion from the study that there was a threshold beyond which an increasing proportion of women had poor clinical outcomes. And so when we look at our overall statistics of viral suppression and we look at it by subgroups, I think we have to consider some of these different variables that are affecting adherence and ultimately viral suppression. So there are data that are available on the impact of these different factors related to HIV outcomes. Depression has been associated with reduced adherence to medication, reduced adherence to medical visits, reduced viral suppression, and higher levels of morbidity and mortality. Women with a history of violence are less likely to have viral suppression. Experiencing physical and other types of violence increases the likelihood that someone's not going to even be tested and know that they have HIV, but also it's going to increase their risk for not accessing or being retained in care. And childhood sexual abuse is particularly a strong risk factor for substance abuse, engaging in risky sex, and then failing to even engage in HIV care and medication adherence. Several studies have shown an association between specific substances of abuse and lack of viral load suppression. And then depression, again, in a study that looked at the relationship between different contextual psychological and environmental factors with adherence. And depression was associated with non-adherence, and fewer depressive symptoms was associated with higher adherence on the spectrum. This was a study looking at a cross-section of HIV-positive individuals who were on ART and also had a current substance use disorder. And the bottom line from this slide is that approximately, first of all, 75% of substance-using cohort were able to achieve viral suppression. So that's good, but it's certainly not where we want it to be. And that it appeared to be less related, the lack of viral suppression appeared less related to the specific substance abuse, but more to the number of criteria for drug dependence. This was a study that's now about 7 years old, but it looked at buprenorphine and naloxone as part of medication-assisted therapy for opiate use disorders and HIV clinical outcomes. And the bottom line is, if you looked at those individuals who were on these drugs for MAT for longer periods of time, they were much more likely to be on antiretroviral therapy and much more likely to have suppression over time. There's a fair amount of data on the treatment of depression, improving outcomes, and reducing depression. It's been associated with both increased adherence and concomitantly viral suppression. Drug use is also been independently associated with poorer outcomes along the depression treatment cascade. So if you have the cascade, which is very similar to the HIV cascade, being able to identify people with depression, get them into care, get them on treatment. So current drug users were most likely to need treatment for depression, but they were, as you might expect, less likely to receive treatment or to have depression remission. And this was from a study, a retrospective cohort study from 2 large HMOs with over 3,300 patients. And they looked at the prevalence of depression in this population was 42%, 15% were being treated with SSRIs. And so they looked at different variables in terms of adherence, in terms of being of viral suppression. And I think the bottom line, these are really fairly busy slides, but the bottom line is that if somebody was on an SSRI and they were adherent to the SSRI, their adherence to ART was similar to somebody who was not depressed, showing that the treatment of depression was pretty critical. And this is from the same study looking at virologic and immunologic control. So again, if they were on therapy for depression with an SSRI and they were adherent to that, their viral load suppression was similar to those who were non-depressed. CD4 count wasn't that different, but if they looked at those who were adherent to their SSRIs, they had statistically greater increases in CD4 cell responses. So I think that to sort of bring this to summary, I think the statistics are pretty incredible in terms of the type of problems we face with these issues in the general population, but the fact that these are, we're more likely to see it in our population of HIV-infected individuals, men and women, and that they have a unique interaction and interrelationship that is affecting some of the adverse outcomes we see. So we're in a fairly unique position to identify individuals who have these problems and then put in place interventions and hopefully modify the conditions, but also improve their HIV outcomes. Now, some of the data here, this is not from the Bartlett Clinic or the Moore Clinic, but I think that a lot of clinicians, general clinicians and even clinicians who treat women and who treat men with HIV may not be as aware as they could be of the interaction between these factors. And from a survey that was done in 2016 here, 50% of Hopkins clinicians rarely or never screened for substance abuse, and 83% of clinicians rarely or never screened for violence. So I think that many of these problems remain invisible, but they are associated with suboptimal outcomes. So we're hoping that this pilot study, the next time, the second part of this presentation, we'll talk a little bit more about the study, about the screening, and a little bit about interventions. So thank you very much for your attention.